Hi everyone. Today we will talk about substance-related and addictive disorders. This week we will focus on key terms used in the field of substance use, abuse and disorder. We will talk about biopsychosocial perspective on substance misuse. We will also talk about diagnostic criteria and classification of different types of substances. Finally, we will identify 3 key trending topics in the area of substance use and misuse. So first, let's talk about substance use. This term really implies that certain psychoactive substances are introduced into the body, for example, by drinking, inhaling or injecting. When someone is said to misuse substances, the amount of substance use does not matter. A small amount used during pregnancy can increase the risk that the child will develop health problems. A small amount of illegal substance can lead to legal problems. A moderate or high amount, if used regularly, can also lead to higher risk of different kinds of cancers over time. When we talk about substance misuse, we use the evidence. We know from research that certain use patterns increase the risk of people to get in trouble. However, this particular individual may or may not end up experiencing problems related to substance use. A person must meet specific criteria to be diagnosed or classified as experiencing a substance use disorder. We will talk about these criteria later in the course. Historically, terms like alcoholism and addiction were used. The Diagnostic and Statistical Manual of Mental Disorders, 4th edition, called it either substance abuse or substance dependence. A key feature of a substance use disorder is that individuals continue using the substance despite significant substance-related problems. There is a significant variation in the individual biological and genetic makeups. Because of this, some people use a substance for the first time and they don't feel as intoxicated as others. They think they can hold their liquor and continue with higher levels of use. Still, the body adapts to the impact of the substance. People need to use more to feel the same effect. One of my clients described it as follows. When you are sober and have your first line of coke or a hit of rock, you get super high. It is the best height you'll feel, and everything else after that will be chasing that first high. What's sad is you never quite feel that same satisfaction. I honestly think you never have enough because you can't really remember how it felt like. So you chase something that even if you got, you would not know. There are a couple of risks related to tolerance. After a period of abstinence, the tolerance will decrease. However, people often remember the levels at which they used to consume before a sober period. When they resume drinking or using drugs after a period of abstinence, they can use too much and risk to overdose. Another situation can be related to drunk driving. Alcohol users can develop quite a remarkable tolerance over time. It's not uncommon for them to drink a bottle of vodka or more without feeling impaired. However, alcohol still impacts their judgment and slows the reaction time. Driving with high blood alcohol level can increase the risk of accidents and legal problems. We tend to pay attention to the problems that arise as a result of substance use. Withdrawal is an interesting phenomenon because it's all about problems that arise when an individual stops using the substance. Alcohol withdrawal symptoms, for instance, include high levels of anxiety, sleep disorders, tremors, nausea and vomiting, sweating, and possible seizures. Symptoms associated with withdrawal from heavy, prolonged marijuana use include irritability, anger, aggression, difficulty concentrating, nervousness, anxiety, sleep disturbances, vivid unpleasant dreams, decreased appetite and weight loss, restlessness, depression, shakiness, sweating, fever, chills, and headache. Opioid withdrawal is linked with depression, nausea/vomiting, muscle pain, runny eyes, runny nose, sweating, diarrhea, fever, and insomnia. Biopsychosocial perspective means that biological, psychological, and social factors are involved in the development, maintenance, and resolution of the substance abuse and disorder. In clinical practice, we often work with clients whose parent or grandparent had substance use problems. It led to increased genetic vulnerability. Growing up, the client has socialized in the drinking family culture. Alcohol was in the fridge, on the table, at birthday parties and at funerals. Client knew more about the use than his or her peers. He knew when mommy gets tired or upset she takes some wine. He would see his dad watching TV with a 6-pack. Had wanted to be like his father, he wanted to try it too. When he first tried it, he fell in love with it right away. And he could hold his liquor, no headaches, no spins the morning after a night of heavy use. And no more worries and anxieties, he could talk to girls and enjoy talking to other folks. It just felt right. Such stories, that we often hear from our clients, help us understand the aspects of the biopsychosocial perspective. DSM-5 views substance use disorder on a continuum of severity across 4 functions. The first function is impaired control overuse. This function includes 4 criteria: 1. Inability to control the amount and the length of use. 2. Persistent desire and inability to cut down or control the pattern of use. 3. Spending a lot of time trying to get the substance, use it, and then recover from the use. And 4. Strong desire, craving, or urge to use. The second function deals with social impairment and consequences of use. This function includes 3 criteria. Criterion 5. Failure to fulfill major roles across main life contexts. At work, at school, or at home. Criterion 6. Repeated use despite persistent social and interpersonal problems. And Criterion 7. Giving up or reducing social activities, work and recreation because of use. The third function deals with the risky use of the substances. This function includes 2 criteria. Criterion 8. Repeated substance use in physically dangerous situations. This includes drunk driving and engaging in risky sexual practices. And Criterion 9. Repeated use despite persistent physical or psychological problems. Notice that the Criterion 9 focuses on such problems as liver problem, sleep, or depression. As you recall, Criterion 6 also focused on recurrent use in spite of the problems. But that criterion dealt with problems in relationships, for example with the spouse or child. Pharmacological criteria are the final grouping. Criteria 10 and 11 focus on the presence of tolerance and withdrawal symptoms. DSM focuses on 10 substance classes. We will talk about them in a minute. One way of organizing the very long list of psychoactive substances is in terms of their actions on the human body. Stimulants typically increase heart rate, increase energy, as well as anxiety, violence, and lead to multiple negative health outcomes, including the risk of overdose. Depressants cause euphoria, mild stimulation, relaxation, lowered inhibition, drowsiness, and can lead to fatal overdose. Cannabinoids cause euphoria, relaxation, slowed reactions, distorted sensory perception, impaired balance and coordination, increased heart rate, increased appetite, impaired learning and memory, anxiety and psychosis. Opioids lead to euphoria, drowsiness and sedation, nausea, impaired coordination, confusion, constipation, slowed breathing, and can result in overdose. Hallucinogens alter perceptions and feelings, cause hallucination, increase heart rate, blood pressure, body temperature, numbness, dizziness, sleeplessness, lead to paranoia and flashback experiences. The use of steroids is associated with muscle growth, deeper voice, facial hair growth, but also with hypertension, changes in blood chemistry, liver damage, aggression, acne, infertility, and other reproductive system changes. Inhalants produce a stimulant effect followed by depression, impaired memory, nervous system disruption, muscle weakness, damage to the cardiovascular system, loss of consciousness, and risk of sudden death. Many drugs, medications, and psychoactive substances are classified by the U.S. Drug Enforcement Agency, DEA, determining the legal status of their distribution and the rigor with which they need to be controlled. Each scheduled substance receives its classification based on evidence concerning 1. Its potential for abuse, and 2. Whether it has current and evidence-supported medical applications in the U.S. Drugs, substances, or chemicals that belong to Schedule 1 are defined as drugs with no currently accepted medical use and a high potential for abuse. Drugs, substances, or chemicals belonging to Schedule 2 are defined as drugs with a high potential for abuse, with use potentially leading to severe psychological or physical dependence. These drugs are also considered dangerous. Drugs, substances, or chemicals under Schedule 3 are defined as drugs with a moderate to low potential for physical and psychological dependence. Schedule 3 drugs abuse potential is less than Schedule 1 and Schedule 2 drugs, but more than Schedule 4. Schedule 4 drugs, substances, or chemicals are defined as drugs with a low potential for abuse and low risk of dependence. Schedule 5 drugs, substances, or chemicals are defined as drugs with lower potential for abuse than Schedule 4 and consist of preparations containing limited quantities of certain narcotics. Schedule 5 drugs are generally used for antidiarrheal, antitussive, and analgesic purposes. The trending topics are topics where practitioners, scholars, investigators, and others may not share a common viewpoint. The most enduring point of contention and debate is how substance use disorders are viewed. The second focuses on the use of harm reduction approaches. Third, involves adoption of a recovery orientation in the design of programs, services, and policies. This slide shows multiple ways in which addiction was defined over time. The term harm reduction first appeared in the literature during the late 1980s and early 1990s. It is used to reduce adverse consequences that are often associated with substance misuse, such as criminality, HIV, other sexually transmitted diseases, hepatitis, or lung disease in case of smoking. A recovery orientation refers to a host of values, beliefs, and behaviors related to how individuals engage in the process of recovery from a substance use disorder. The recovery orientation is fundamentally informed by the individual's own definitions of the problems, the solutions, and subjective experiences, rather than those being imposed by others. Built into this orientation are issues such as having individuals define for themselves what constitutes recovery. This may or may not include abstinence as a goal, for instance. Another aspect has to do with adopting a holistic view, where individuals' recovery is embedded in a context of all life structures, functions, and wellness, including their future growth and development as a person. Not just changes in past substance use behavior. Thus, recovery does not simply mean achieving the absence of disease. It means promoting wellness across all life domains.